Hello, everyone. This is Professor DePaulo. Welcome you back to Abnormal Psychology, Psych 260, Chapter 3, Part 2. And we're going to continue where we left off with the behavioral model. And the behavioral model is often combined with the cognitive model to form what is traditionally known as cognitive behavioral therapy, or CBT, which is one of the most popular modalities used to treat any kind of psychopathology, especially anxiety and depression, which are very responsive to CBT. But I'm going to break them up separately first. I'm going to talk about the behavioral model first and then the cognitive model afterwards. But generally, they are combined. The behavioral model looks at how our actions and the responses of those actions determine our behavior, right? So uh, reinforcements such as positive reinforcement and negative reinforcement, and punishment, which also has a positive and negative component as well. Remember that reinforcement increases the behavior and punishment decreases the behavior. And those are very powerful uh, outcomes that can shape our behavior on a day-to-day basis. So there are three components for the behavioral model. We have operant conditioning, which is rewards and punishments, which is technically reinforcements and punishments. Reinforcements are rewards. Modeling, which is known as vicarious conditioning, which is observational learning. You watch somebody, you imitate them, you learn. And classical conditioning, which is paired associations. And this is the Pavlovian idea with the bell and the food that leads to the salivation response. All three of these different components of the behavioral model can lead to normal or abnormal behavior. And they're difficult to correct because in the case of a lot of abnormal responses that result from, say, classical conditioning, like fear, the fear response is one trial learning, and it's easily established but much more difficult to break through it. You can break through it. You can deal with a phobia, fairly easily as far as, correcting any kind of psychopathology is concerned. It won't take that long. But it's not it's much more simpler to form the phobia than it is to actually erase the phobia or extinguish the negative response that you have. So operant conditioning is the term we use where humans and animals learn to behave a certain way as a result of receiving rewards or getting punished. And rewards are much more beneficial than punishment. They work better. Punishment is not the answer. Punishment can change a behavior in the short term, but it doesn't have an effect in the long term. So the best way to change a maladaptive behavior is to reward an alternative behavior instead of punishing the behavior. There's also some evidence that punishment at a very young age models aggression. So a child that's physically punished especially is more likely to engage in aggressive behaviors, including bullying later in life. So if you have to use any kind of punishment to decrease a behavior, you would prefer to use what's called negative punishment, where you take something that's desirable away from someone as a means of punishment. And amongst many teens and younger kids these days, that's their phone. They value their phone, you take their phone away, that's a form of negative punishment. That's more effective than hitting the child or hitting the teenager. That's called positive punishment. So physical punishment is known as positive punishment, but there's nothing positive about it. It's actually very bad in the long term, contrary to what some people believe. So if you have to decrease a behavior, use negative punishment, take something positive away from the person that you're trying to, child or the adolescent you're trying to change their behavior, and then reward an alternative behavior. We also use modeling, which is observational learning. So an individual can learn good or bad by modeling someone's behavior. You can even develop phobias by modeling. If you watch someone get bit by a dog, you might develop a fear of dogs from just watching someone get bit. And you've modeled that fear response that that person who got bit is actually showing. So you can model positive and negative behavior. You saw this with Bandura's study of the Bobo doll, where the adults beat up the Bobo doll. What did the children do? They went in and they beat up the Bobo doll. So it works both ways, good and bad behavior. Classical conditioning is another way of learning a maladaptive response, especially a fear response. And this occurs by temporal association. So when two events occur close together in time, they become linked, and the organism learns to predict the subsequent behavior, the second behavior, from the first stimulus. So in this case, Pavlov, the Russian physiologist, did a series of studies using dogs and using meat. And what he did was he rang a bell right before he presented the dog's food, and the dog would salivate. Now, the dog naturally salivates in response to food, but by pairing the bell before the food, and he kept doing bell, food, bell, food, bell, food, eventually the dog learned that the bell predicted food, and the dog would salivate to the bell by itself. And this is very easily generalized to a phobia. So let's say, I said the last time about the dog bite, you can easily condition the dog bite to the surroundings of where the dog bite takes place. Or let's talk about agoraphobia, which is a complex phobia where people generally have difficulty leaving their comfort zone, and in severe cases, that comfort zone is their house. It can even be their own bedroom in the most extreme circumstances. So what happens with agoraphobia is someone has a panic attack, which is a abnormal physiological response that creates anxiety. So it leads to like rapid heartbeat, sweating, tremendous amounts of anxiety because you don't know where it's coming from. It's kind of unknown origin. It's not inherently dangerous, but it's very disturbing. And people will pair the panic reaction to their surroundings. So if you have a panic attack while you're in the grocery store, well, now you've conditioned the grocery store to the panic attack, and you want to avoid the grocery store because you're afraid of it. You're afraid you're going to get a panic attack there because you've classically conditioned it. If you have a panic attack while you're at school, then you don't want to go to school because you're afraid of having a panic attack. And eventually, you can be afraid of having a panic attack basically anywhere. And that's what leads to severe agoraphobia. And the only way to break that is to venture out and either tolerate the panic attack or suppress the panic attack. The panic attack can be suppressed with antidepressants and anti-anxiety drugs. But you can also tolerate the panic attack. It's difficult, but people can learn to accept it and just kind of write it out, knowing that it's going to end. And that's basically what's done with simple phobia too. Agoraphobia is a complex phobia, but with the simple phobia, people will learn to kind of write out the anxiety, to sort of tolerate it. And the more you tolerate it, eventually the association between the environment and the panic will break. It'll be extinguished. The fear will be extinguished, and you can then go about, your normal life. So the problem with fear, fear association or fear learning is that it occurs really quickly. So you only have to have one panic attack to associate the surroundings with that panic attack, and then you learn to avoid. So it can happen really, really quickly where you start, avoiding to the point where you have severe agoraphobia and you're kind of stuck. You can't go anywhere because it only took one panic attack in this place and another panic attack somewhere else, and eventually you want nothing to do with, I can't go anywhere because I'm going to get a panic attack, or I'm afraid I'll have a panic attack and I won't be able to escape. So it's really detrimental in that we acquire fear quickly. And there's a reason from evolution that we do this. It's because acquiring a fear response quickly, conditioning a fear response in one trial led to our ancestors surviving. you think about our ancestors during hunter-gatherer days, if they encountered a danger and they didn't learn to avoid that danger, they would die. And if they died, they wouldn't be able to reproduce, they wouldn't be able to pass on their genes. And as a result, fear became selected. Natural selection said fear is essential to our survival. And unfortunately, thousands of years later, we still have it. It's like something you can't get rid of. We're never going to, totally get rid of the fear response, because even today, under certain circumstances, it can be helpful. 99% of the time, the anxiety response, the panic response is not helpful. But that maybe less than 1% of the time, it can be helpful. Like if there's a fire, anxiety is a good motivator to get you out of the building. So in that case, a fear response saves your life. But there's not many of those situations in our lives, hopefully, these days. And so for the most part, the fear response, the anxiety response is a burden to us and not a benefit. Here's a drawing diagram of the classical conditional response. You present meat, which is the unconditioned stimulus. It leads to salivation, which is the unconditioned response. Unconditioned means unlearned. It's naturally occurring. So meat naturally causes a dog to salivate. If you pair the tone with the meat, where the tone occurs first, so tone, meat, tone, meat, tone, meat, eventually the tone, which was the neutral stimulus, because it didn't produce a response by itself, if it's associated with the unconditioned stimulus, the meat, it then becomes known as the conditioned stimulus, and it will predict the salivation response, which is the conditioned response. So conditioned just means learned. It's a learned behavior, a learned stimulus, and a learned response. Whereas the unconditioned stimulus or unconditioned response is unlearned. So how do you deal with anxiety, phobia, etc., that are results of behavioral, either classical conditioning or in operant conditioning in some circumstances? And the way to extinguish it, classically conditioned fears, the way to extinguish it is through systematic desensitization. Well, that's one way. There's other ways that we'll talk about in future chapters. But systematic desensitization is a very popular technique, and it's step by step, where you gradually approach the feared stimulus, gradually, and you perform relaxation exercises. So if you're really afraid of dogs, you may start with a picture of a dog. If that picture of a dog elicits anxiety, you want to perform relaxation exercises like meditation or deep breathing to try to tolerate it. So you always start with pictures first. Then once you're comfortable with pictures, you can start with the real thing. So you bring a real dog in, and you keep the dog far away. And then the patient or the client, let's use the word client because patient's only used when someone's in a hospital or they're getting psychoanalysis. The client then approaches very gradually, and their anxiety will heighten, and they will once again work on the relaxation skills. And they will gradually, in baby steps, approach the feared stimulus to the point where eventually they'll reach out and pet the dog. That'll be like the last step. And that might take a long time to get there, depending on how severe the phobia is. It could take many weeks to get to the point where you're in direct contact with the phobic stimulus. But it's done very gradually and with relaxation techniques. It's not effective to take like a large dose of Ativan or Xanax and then do this, because the extinguishing of the fear response will not occur when you take high dosages of benzodiazepines or anti-anxiety drugs. So you have to be really careful with how much of these benzodiazepines you take while you're trying to work on the extinguishing of the feared response or the phobia. Because that extinguishing will not occur with moderate to high doses of these drugs. It can occur with antidepressants. So if the phobia is so severe that the gradual, the systematic desensitization technique might be too difficult, then the client can take antidepressants, and the antidepressants should not interfere in the extinguishing of the fear response. At least that's what we know of these drugs so far. They seem to be okay with that. So assessing the behavioral model, it really works with regards to anxiety. It can also work with depression, right? So the behavioral model in the case of depression says that people are having a lack of positive reinforcement in their lives. So if you have no positive reinforcers in your life, that means you have no rewards, you're going to be depressed. It's pretty as simple as that. If nothing is rewarding, uh, you're going to be depressed. And there's another theory that's more widespread and it's been studied, in greater depth, and that's learned helplessness. And we'll talk about this when we get to the depression chapter, that if you learn that every response that you take gets punished, so no matter what you do, you're being punished, eventually you will give up. You will become apathetic, and that inactive state will lead to depression. And it's called learned helplessness, and it was developed by Martin Seligman, who is a pioneer in uh, these areas that involve, you know, behavioral components of depression. He was also involved in the positive psychology movement, but he's not anymore. At least according to him, he's not involved anymore. So that was a pretty prominent study of learned helplessness. So it's effective. The behavioral model is effective at demonstrating how feared response gets conditioned and how depression could occur through operant conditioning. And phobias can develop through modeling as well. Aggressive behavior can be developed through modeling. So if you're a child that's in an abusive family and you see your father physically abuse your mother, you're more likely when you grow up to engage in the same kind of domestic violence, unfortunately. And it's because that behavior has been modeled at a young age. And so you're learning by watching. So it puts you at higher risk as you get older of repeating the same mistake. And that's why there's generations of abusive relationships. So there's a lot that the behavioral model can cover. The weaknesses are that, symptoms may not occur through conditioning. I mean, it's not evident that everything is done through conditioning. For example, a panic attack. What's the cause of a panic attack through conditioning? There is no cause. We think of a panic attack as mostly biological. There's nothing in the behaviorist arsenal to explain this random bursts of extreme anxiety. There's also evidence that it's too simplistic and it's very limited. So you can't separate the behavior from the cognitive because thought and action go together, and it's really hard to simplify, to separate them. So you're better off looking at behavioral in the context of cognitive, and that becomes cognitive behavioral therapy. So that's the way we generally look at things. But from just isolating the behavioral model, it does account for certain things. It doesn't account for the role of cognition because the behaviorists didn't believe in cognition. Skinner and Watson never thought that thoughts could influence behaviors. So they saw people as basically machines. That if you give them the appropriate stimulus or you give them the appropriate rewards and punishments, you can basically manufacture the behavior. We know that's overly simplistic. You have to look at the cognitive side of things as well. And that's where the cognitive approach comes in. The cognitive model looks at how thoughts influence behaviors. So behaviors are not in isolation, they always accompany thoughts. And these thoughts, if they're negative, if they tend to be illogical, they can severely hinder a person in the long run. Just looking at the theoretical theoretical orientations briefly, you can see that the majority of people are cognitive, and you see a big chunk of behavioral, and you can really combine those into cognitive behavioral. That's about 38%. That's a huge chunk of people that are cognitive or behavioral or cognitive behavioral. Clinicians. If you see eclectic means more than one approach. So that can include cognitive behavioral and other approaches as well. That's 29%. So over half are either CBT or multimodal. Psychodynamic, only 15%. You're going to see even smaller amounts. If I had just psychoanalytic up here, it would be even less. But all the psychodynamic and the psychoanalytic is 15%, which is it's a portion, but it's not a huge portion. And then you see the client-centered at 1%. We're going to talk about that. The humanistic. You see family systems at 3%. Gestalt at 1%. So there's really not much going on here other than cognitive behavioral, psychodynamic, and eclectic, which is multimodal. You don't see much in the way of the humanistic psychology here in modern days. You don't see it. You're going to see mainly in terms of modalities. You're going to see mainly psychoanalytic, psychodynamic, CBT, cognitive behavioral. You'll see DBT. DBT is not on this chart, but dialectical behavioral therapy. We'll talk about that when we get to borderline personality disorder, and that's also involved in substance abuse. Dialectical behavioral therapy. But those are the main ones. You're not going to see too much other than those three, and then obviously the psychiatric movement with drugs and biological treatments. And that's where the focus is today. I mean, there's a lot of family-oriented therapy, but that family therapy is generally cognitive behaviorally oriented. But we'll talk briefly about humanistic just to show you that it does exist, even though not a lot of people are practicing it today. Going back to cognitive, we know that faulty assumptions and attitudes and illogical thoughts are at the heart of why people have mental disorders. Remember that cognitive behavioral primarily, once again, are focusing on anxiety, depression. Anxiety and depression are the vast majority of all people that are diagnosed. So I keep coming back to this because that's where basically almost everybody is. Yes, there's going to be some bipolar, and are you going to treat someone with bipolar with cognitive therapy or cognitive behavioral therapy? You could use it, but it's not going to be as effective. So when you have like bipolar, you're going to have to stabilize generally with medication, especially if they're manic. Then it becomes a bigger problem if they have full-blown mania. And we'll get to that later, but the therapy for those kind of disorders is a little bit trickier. Therapy for, say, obsessive-compulsive disorder, it can work. It can work. Medication can help with that too. That's a little more severe. Post-traumatic stress disorder, there's variants of cognitive behavioral therapy that we'll talk about for that. But when I talk about these cognitive issues, it's mainly focusing on anxiety and depression. Anxiety, there's lots of faulty assumptions and attitudes. There's lots of that with anxiety. People that are anxious worry about things that they shouldn't worry about. They believe things that are not true. They believe they're in danger when they're not. Those are faulty assumptions and attitudes. People with anxiety have the common two words they always utter over and over again. What if? What if? What if I fail this class? What if I lose my job? What if my significant other breaks up with me? What if I get into a big argument with my parents? What if I lose a lot of money? What if I can't afford to pay my rent? What if I get sick? The what if never stops. It's a very key symptom of anxiety is what if. And the what if is a faulty assumption and attitude. It doesn't make any sense. Because if you were to look at the what if statements that you make, there's no support for them. What if you fail the exam? Well, what if you fail the exam? I'll drop out of school. I'll be working in my shitty job forever. Why? Why would you say that? There's no reason to say that. There's no evidence to support this. It's disasterizing. It's the worst case scenario. And that is illogical. That's a faulty assumption. But we live our lives this way because it's become ingrained in us. It's a negative automatic thought. That what if is in the back of our mind. What if, what if, what if? So the cognitive therapist, and by extension the cognitive behavioral therapist, is going to focus on what if. You're going to challenge what if and show that these what if statements are not true. So stop thinking about them. This is linked to illogical thought patterns and overgeneralization. That's what I mean by disasterizing. You take one aspect of your life and you generalize it to everything, and it's all going to hell. You're falling apart. You'll never recover. You'll never overcome it. You're going to be miserable forever. You're going to be poor forever. You're going to be suffering forever. You're going to be in pain forever. Really? Why? I mean, it's easy to believe that. But why? What is the evidence? Most of us don't think of the evidence to support these erroneous beliefs. They're just in our head, and we can't get rid of them. But if we were actually to analyze these beliefs, we'd find out that they're completely ridiculous. And that's a lot of what cognitive and cognitive behavioral therapy is centered around, is addressing these illogical thoughts, these faulty assumptions, these problematic attitudes, and showing that they're not real. And we've probably had them for many years of our lives. And do you get them from your parents? Maybe. You grow up in a household with a bunch of anxious, an anxious mother, an anxious father, anxious siblings. There's no doubt that it's going to carry over. It doesn't mean it's necessarily genetic. It could be partly genetic. But if you live with people and you've observed their behavior for many years, you may pick up some of their tendencies. And some of their tendencies could be having these negative automatic thoughts that are illogical. So it takes a while to break through this. It's a lot of work. And to be honest with you, most people aren't ready for it. They're not ready for the work. They want to take a pill and they want to get better. They don't want to put in the hard work it takes to overcome and challenge these negative thoughts and deal with them, because it's going to take a lot of work. It's not something you do in one day and you're better. You have to challenge them over and over again. It's going to take months, if not years. You've had these thoughts for probably at least a decade, if not more, of your life. It's not something you snap your fingers and it's better. And most people don't want to put the work in. And there is no drug. I mean, a drug will reduce anxiety temporarily. There's no guarantee that drug's going to work for you the rest of your life. It probably won't. You probably will build tolerance. You probably will have to take more of the drug. And there's no guarantee the drug will work at all, even if you increase it. And then you got to switch drugs. And now you're going from one drug to another drug, or to a combination of drugs. Right? And you're not really fixing the problem. You're dealing with it. You're treating the problem pharmacologically, but you're not changing your thoughts. You're not getting rid of these negative automatic thoughts permanently. They're still there. Once you stop taking the drug, the anxiety is going to come back. So it's important that if medication is needed, that it should be accompanied with psychotherapy. Because by itself, it's not a long-term outcome, positive outcome, just taking the medication, because you're going to be taking lots of different medications. Uh, it doesn't magically get rid of these problems. Now, Aaron Beck was the founder of cognitive psychology, of cognitive therapy, and he thought of the negative automatic thoughts that was attributed to him. The vicious cycle of negative automatic thoughts that they're just there and you can't get rid of them. So people need to overcome their problems by changing their thought process. And there's ways to do this. I mean, there's actually workbooks. One workbook that's used all the time that's very effective is the Anxiety and Phobia workbook by Bourne, Bourne. And that's used a lot of times as a workbook in a cognitive behavioral setting. Could you do it by yourself? Probably. Is it as effective as doing it in conjunction with your therapist? Probably not. It's probably effective to do it as part of your therapy. But it is effective for trying to change these thought patterns. So Aaron Beck's model is primarily dealt with in treating depression, but it's also involved in anxiety because these negative automatic thoughts can cause anxiety. They can also cause depression. They tend to go together. The treatment is very similar. The cause is very similar. Anxiety and depression are very highly comorbid. So the strengths of the cognitive model, they have very broad appeal. Cognitive behavioral therapy is huge. It's highly respected. You can research it. The therapies are effective and it can be short term. So if you have just a simple phobia, you might be able to do cognitive behavioral therapy for a few months to deal with your phobia effectively. Obviously, if it's agoraphobia, it's going to take a lot longer. But it's amenable to shorter treatments than, say, psychoanalysis is. The weakness are that it doesn't work for everybody and it's difficult to do. It's difficult to change your negative thought patterns. It's not the same as behavioral therapy where you can pair things up and you can desensitize much easier than actually changing these thought patterns. This has also been combined with mindfulness-based techniques. So now you have cognitive therapy that's involving mindfulness. Is it more effective? I don't know yet. We need to look for the data. But mindfulness has become, which is meditation, has become a big part of the cognitive behavioral and the dialectical behavioral model. The dialectical behavioral model has mindfulness as a major component of it. So they de-emphasize the thought and they emphasize the being aware in the present. So mindfulness is being aware in the present moment rather than looking at your negative thought patterns. It's about being aware, monitoring your emotions, monitoring your body, monitoring how you feel in the present moment. And that could be effective compared to, and maybe easier to achieve than changing the negative thought patterns. You can learn to meditate pretty quickly. Is it going to be the same effectiveness? You would have to look to see how it's compared. I am looking at, in my own personal research, I am looking at mindfulness and comparing it to things like traditional stress management techniques like journaling, and also comparing it to things like binaural beats, listening to these two beats through headphones that differ slightly in frequency. So there's a wide variety of these alternative techniques out there that can maybe fill some of the void or fill some of the need that the cognitive behavioral approach was was tackling. So there's a lot of competition. I don't know if I would consider that a weakness, but it's just, with mindfulness-based techniques in there, they're an alternative to the traditional cognitive behavioral therapies. Now let's move to the humanistic approach, the humanistic existential model. This is the model that was founded by Carl Rogers and Abraham Maslow. You might be familiar with Maslow's hierarchy of needs, where you have to meet your shelter needs and your food needs and your health needs before you meet, at the top, self-actualization, becoming the best you can be. So the humanistic existential model looks at people as cooperative, constructive, friendly, good, and they're driven to self-actualize. That means become the best they can be, best person they can be, self-actualization. So there's a big emphasis on self-determination and choice and responsibility. Whereas the cognitive model looks at people as being maybe sometimes overwhelmed by their negative thought patterns, their illogical thought patterns. That's kind of a negative state, right? If people are dominated by illogical thought patterns. The humanistic view says the opposite. It says you're not dominated by illogical thought patterns. You're not negative. You're good in general. People are good in general, and they need to self-actualize. But the environment kind of prevents us sometimes from being self-actualized. It hinders our quest for self-actualization. So Carl Rogers, who was one of the founders of this technique, the humanistic technique, believed that all humans need unconditional positive regard. Unconditional positive regard means people need to be valued for who they are, accepted for who they are, not judged in any way. Flaws and all. Now, is that common in everyday life? No. And since this is not common in everyday life, it leads to conditions of worth, which means you need to kind of fulfill the role that other people want of you. They're not happy with just who you are. They want you to be a certain way. And that leads to conditions of worth. You can't be exactly who you are. You need to change for people. And if you change for people, you can't self-actualize because you have no idea what you really need because you're too busy changing yourself for other people. Now, that could be in a relationship very easily. Your partner doesn't really accept who you are, and you need to put on a facade around them, or you need to engage in behaviors just to please them that you may not really want to do. You may not feel comfortable with them. You may feel like to change yourself or compromise yourself for them. Very common. In a job, of course, you may not be doing what you want to do. You may not be able to say what you want to say to your boss because you're afraid they're going to fire you. So these processes prevent you from becoming self-actualized. And as a result, you're more prone to psychopathology. I mean, you're in an unhappy relationship where you have to change who you really are, put a face on to pretend you're someone you're not. You feel like you can't act naturally. That's going to lead to problems. Same with a job. You're going to have a very unhappy relationship. It's going to make you more prone to all kinds of physical and mental illness, and same thing with your job. So you need to be pushed back towards self-actualization, which means quitting your job, quitting your relationship, and trying to fulfill, trying to proceed in a way that sort of is very fulfilling to you and leads you to become the best you could be, in a true manner. Be true to yourself. So that's what the humanistic technique is about. Rogers was very supportive of his clients. He did not judge them. Whereas some of the cognitive theorists, I'm not talking about Aaron Beck per se, but you had rational emotive therapy, which is another version of cognitive therapy that tends to be very combative. So not all cognitive therapies are hold your hand, everything's going to be okay. They tend to be a little bit more challenging, this illogical way of thinking. Whereas Rogers, in his client-centered approach, which is part of the humanistic approach in general, Rogers made everybody feel at ease. He showed unconditional positive regard, which means he was not judgmental. He was supportive. He showed empathy, which means he understood what his clients were feeling, how they felt, and understood their behaviors in context. And he was very genuine. So he was completely non-judgmental. So instead of challenging your thought patterns, which can be kind of, tough and not so friendly, right? If your cognitive therapist is not so friendly, like Albert Ellis, who was the founder of rational emotive therapy, was Albert Ellis, and I had met Albert Ellis years ago. He was not the friendliest guy to talk to. He was a difficult person, and in his therapy sessions, he was very difficult to his clients. He was very challenging, very combative, to try to break down these negative thought patterns, these illogical thought patterns. He was in their face, arguing with them. Whereas Rogers is hold your hand, everything's going to be okay, nothing's ever going to go wrong. You're supported, it's okay, you've made mistakes, you're on your way to fulfilling your potential. So completely non-judgmental, hold your hand kind of fashion. Now, what works with one person may not work for another. Some people need to have their hand held, need to be encouraged. That's the way they change. Other people, that's not going to work. They need to be challenged. So if you're someone that needs to be challenged, then the cognitive therapies might be more beneficial. If you're someone that, if you're challenged, you're going to fall apart, you need to be gently nudged, and you need someone to hold your hand through the whole thing. That's when the humanistic approach is effective. The problem with this humanistic approach is there's very little research on it. Because how do you know if you've reached self-actualization? You don't. You fulfilled your potential. What does that mean? I don't know. That means different things to different people. So how do you know it works? How do you know what it is? It's kind of like psychoanalysis. You can't study it because you can't measure self-actualization. Really, you could try, but it's very difficult. Does it work? Yeah, it works for some people. Some people it doesn't work for, just like every other therapy. The cognitive approach or the behavioral approach is much more prevalent than the humanistic approach in terms of therapy. And it's even less prevalent now than psychoanalysis and psychodynamic approaches. So this Rogerian technique has kind of fallen out of favor, but it can be effective. I also want to mention spiritual interventions. So we know through recent research that a sense of spirituality, I'm not talking about religion. It's not a particular religion or you're very religious, but just spiritual. Spirituality has led to more positive outcomes in therapy. That does not mean that you have to join a particular religion. That does not mean you have to attend particular religious ceremonies on a regular basis. That's not what we're measuring. We're measuring spirituality in terms of, do you believe there's something out there in the world other than what we can see and feel and touch, and hear. And some people are more open to this spiritual nature of the world, and other people are not. And what we found is people that are more spiritual tend to have better outcomes. And there's different ways to measure spirituality. There's even scales to measure spirituality now. But it's not specifically religious. It's more of a belief in something more than we can just see, touch, hear, etc. So let's access the humanistic existential model. It's a very optimistic, it's a very friendly, encouraging therapy. It emphasizes the strengths of the individual, the ability of the individual to improve, to self-actualize. The weakness is it's difficult to research. There's not much research on it, and therefore people don't believe that it works. The hand-holding approach, the gently, it's going to be okay, you're going to succeed. Some people say, well, why not challenge the client? It works better. They have negative thought patterns. We can actually see those negative thought patterns. We can change that. In terms of the humanistic approach, we can't measure self-actualization. So how do I know that you're more self-actualized now than you were, a few months ago before you started therapy? You don't. You don't know if you've become self-actualized. You don't know how far you are away from being self-actualized. And is everyone self-actualized differently? Those are a lot of questions that are hard to answer. So that's why the humanistic approach has been kind of put down a bit. It's put down because it's hard to research, just like psychoanalysis. Hard to research. And if you can't research it, how do you know it's effective? That's the issue. However, I like to get, I would want you to see the idea of therapy as not, I need to pick a set of finite choices. I need to pick one of these techniques. That's not the case at all. You can be eclectic. You can use multiple techniques if you know what you're doing. And that might be beneficial for your client. So I like to keep an open mind to different things. And not just be like, I'm a cognitive person, I reject everything else. No. Or I'm a psychoanalyst, I reject everything else. No. You have to be accepting of different techniques and try to use them in a way to benefit your client. And each client is different. And so the more tools you have, the more flexible you are with your clients and the better, outcome you're going to achieve. Because you'll know this person needs a more cognitive approach, this person needs a more hand-holding humanistic approach, and then you're able to apply it successfully. So this idea of being eclectic or using multiple techniques, that's a real benefit to your client, to the broad array of clients that you're going to have. The last thing I want to talk about in this part 2 here is this idea of diathesis stress model. So diathesis is a predisposition. It could be genetic, it could be psychological, it could be socially based. Generally, we think of it as some biological or some genetic predisposition. And then the stressor comes in. And the stressor combined with the predisposition leads to the illness. For example, you might have a genetic predisposition to depression, but you're not depressed. However, you experience a major stressor that you can't cope with, and that triggers the episode of depression. And that's what's known as diathesis stress model. You have a predisposition, often we think of it as biological or genetic, and then we have a stressor, environmental stressor, that you cannot cope with, you don't have the resources to cope with, and that triggers the start of the disorder. And this was brought to my attention when I was talking to someone with schizophrenia, and he had schizophrenia for many years. And I was asking him about and obviously he was being treated, so he was able to have a conversation. He wasn't, totally psychotic. And I was asking him about what happened, how did you get, when it was the first time you knew you were schizophrenic. And he told me, well, I got divorced from my wife, and I became schizophrenic right after that. So in that case, he had this genetic predisposition to schizophrenia, and then he had a major life stressor like divorce, which is one of the biggest life stressors you can have, and that triggered his full-blown schizophrenia. And it was a very sad tale to hear, but it's something that's pretty common. How do you know you have a genetic predisposition? You don't, because once again, we haven't mapped all the genes that code for each particular disorder. So even if you have like 3 genes that we've researched that are associated with schizophrenia, doesn't mean that you necessarily have a biological predisposition, because we don't know all the genes involved. There could be many hundreds of genes involved. We just don't know enough. So it's kind of hard to know if you have a genetic or biological predisposition. There is some evidence in schizophrenia that there's viral transmission that could play a role during before birth, in utero. I mean, there's a variety of different ideas, but in terms of genetic predispositions, it's very hard to know. There's no mapping of you're predisposed to depression, you're predisposed to anxiety. You can't get that. Maybe 20, 30 years from now we'll have that, but I don't know. The human brain, the human body is just so complicated. So maybe eventually, many years from now, we'll be able to genetically screen for everything, and then we'll do gene therapy, and you won't have to take drugs. The gene therapy will just fix whatever predisposition you have. You'll never get the disorder. So who knows? But that's it for chapter 3, part 2. Hope you enjoyed it. If you have any questions, let me know. You can email me, come to office hours, or ask during the next class. See you next time.